Dear friends and colleagues, this is my great pleasure and honor to be invited to your conference. Thank you very much, and thanks to the organizers. I'm Jan Bělohlávek. I'm the cardiac intensivist, and my main focus of clinical practice and research is cardiac arrest and resuscitation. I'm going to talk today about ECPR, which stands for extracorporeal cardiopulmonary resuscitation in out-of-hospital cardiac arrest, and I'll tell you some words about the past, present, and future. This is my disclosures. The past of the ECPR was, or maybe still is, that the refractory out-of-hospital cardiac arrest has poor outcome. And ECPR is one of the promising methods to improve an outcome of patients with such a severe disease, which has a very, very poor prognosis. Still, benefit of ECPR in refractory out-of-hospital cardiac arrest remains uncertain. What is the background? So if you look at the EUREKA-1 study, which has been studied from 2014, and the EUREKA-2 from 2017 with very similar results, you can see the overall survival of patients with out-of-hospital cardiac arrest being 10.3%. And those were patients with 22% ventricular fibrillation as an initial rhythm, almost 70% of those patients with bystander CPR, and 25% of return of spontaneous circulation on arrival. And you see there is heterogeneous results within Europe. This is Europe results, our country, somewhere over here, around 15% of survival. What is also interesting on the left-hand side is the distribution of patients with return of spontaneous circulation and patients who are being transported under ongoing CPR. And what you can see is very heterogeneous actually in between the countries, and showing how one country actually is prone to use the CPR with ongoing CPR, and the other countries not. So this is something which is being done in centers who are ECMO centers and who prefer to take care in hospital usually for patients with refractory out-of-hospital cardiac arrest. The other data we have is that the outcome of patients who are being treated in the invasive cardiovascular centers is much, much better than those patients who are treated at the regional hospitals without advanced cardiovascular care. And the other content and context is that in the recent years, there's been a steep rise in the use of extracorporeal life support in patients with both respiratory and cardiac failure. And you can see that probably in 2021, there has been many, many more patients due to COVID pandemics treated, and we were waiting for those data, which are still not being published. In terms of cardiac arrest and in terms of refractory cardiac arrest, it's everything related to time. This is a study from the US showing the proportional decrease in the chance of survival in those patients resuscitated more than, let's say, 14, 15 minutes, where we get into the survival of around 2%. So very poor survival with prolonged cardiac arrest. This is a similar study comparing number of defibrillations related to survival. In this study, almost 20,000 patients have been treated. And you see, if we need 6 to 8 defibrillations, the chance for survival goes down below 10%. So again, this is a typical refractory population, refractory ventricular fibrillation of patients with out-of-hospital cardiac arrest who have a very, very poor prognosis. And this study from Canada, while showing the same relationship between the time and the chance for survival here, 15 minutes of CPR, about 10% of survival. If we look at the ROC curve, this study nicely shown that in the 8th and 24th minute, 50 and 90% of survivors already reach return of spontaneous circulation. What does it mean? It means that if you resuscitate more than 24 minutes and you don't have a ROSC at that point, the chance for the patient to get a ROSC first and mainly to survive is very, very low. And the breaking point is 16 minutes here, based on the ROC curve. So within 16 minutes of professional CPR, we should decide what we are going to do within the next 10 minutes in case that the patient still doesn't have return of spontaneous circulation. And this is exactly the question for ECPR, which is a continuation in CPR using mechanical circulatory support. It's reserved just for refractory cardiac arrest, and VA ECMO is the device we use. So typical VA ECMO with venous cannula implanted into the right atrium or inferior vena cava, pump, oxygenator, and back to the arterial circuit. And here you can see a patient post CPR on the ICU. If you look to the data on ECPR, this is also registry data from the United States. You see the increasing number of ECPR cases in past years and steady survival somewhere around 30%. This is combined population of in-hospital and out-of-hospital cardiac arrest, and we know well that a in-hospital ECPR is for patients who got cardiac arrest in hospital is much, much better than for out-of-hospital cardiac arrest. But this is steady despite the fact that there has been increase in age and the comorbidities over time. Training is extremely important for ECPR teams. It's kind of a battlefield, and it's really all about the time and a lot of hope we can offer to our patients and to the personnel, and also some despair. And our approach is that we are training the team. We are doing a simulation trainings, and it's kind of a pit stop training. And I always show to my colleagues in the team that the team has to train similarly as the members of the pit stop. And let's have a short look how they work. You see 25 men taking care for changing wheels and filling the fuel into the Formula One, and it takes less than 2 seconds to do everything. And what is interesting, and here you see the world record, 1.91 seconds. What is interesting in this is that those teams train 3 times per week from the morning to the evening, whole the year, to be able to perform such a fast, coordinated teamwork. So definitely training for ECPR is necessary. How does the optimal patient for ECPR looks like? We said the patient has to have a refractory cardiac arrest, so meaning that he has to be resuscitated for at least 15 to 16 minutes, still without return of spontaneous circulation, with no comorbidities, witnessed cardiac arrest, possibly by EMS or in a public place. We hope for correctable cause like acute coronary syndromes. We prefer shockable rhythms, and intermittent ROSC are very optimal patients. And of course, short transport and reaching time should be preferred to decrease the time from collapse to ECMO or return of spontaneous circulation. In our institution, we perform ECPR in hospital in the cath lab, and this is how the cath lab is being prepared for a patient on Lucas cardiopulmonary resuscitation coming for ECPR. We have an echo, we have an ECMO device, of course, we have a defibrillator, we use nurse for tissue perfusion monitoring, of course, suction device, ventilator, and Lucas carbon plate to be able to perform X-ray during the CPR. And the team consists usually of intensivists, interventional cardiologists, ICU nurse, cath lab nurses, perfusionists, and the data manager to be able to store the data. So very briefly how the ECPR looks like. This is a typical scenario of a patient who is being resuscitated for out-of-hospital cardiac arrest, brought up to cath lab. You see mechanical CPR on the cath lab table, data manager taking temperature. This is a nurse probes on the forehead for measuring tissue perfusion. And this intensivist takes care for the airways and for the overall coordination of the CPR. And in the meantime, the diagnostics goes on with a ultrasound and transthoracic echo and the cannulation of extracorporeal circuit. So here you see that the patient's been cannulated under CPR and is on the extracorporeal circuit, and we continue with the diagnostics. We immediately perform coronary angiography, and we hope for some cause of cardiac arrest. And this is one of those typical causes, proximal LAD occlusion, which is very easy to fix, actually, to open and fix, but we needed time. So putting a patient on ECMO brings us a possibility of time to fix this and to get a myocardial infarction to recovery or myocardium to recovery. Patients after ECPR usually have a very difficult ICU care. They usually have multiple organ failures because they are resuscitated for 50 to 60 minutes sometimes, and they got multiple organ failures. This is a typical scenario for a patient being resuscitated, in this case for 51 minutes, and a prolonged ICU care over tracheostomy to possibly normal life. This is another example of a lady who was 75 minutes on Lucas for out of hospital cardiac arrest. She had this sport model of ECMO for 1 month. So we are not able to wean her from ECMO, so she was transferred to LVAD implantation, and ultimately she's been transplanted with the heart. So how is the present data? What is the present data showing us? This is data from Minneapolis, nicely demonstrating the relationship between the time in ECPR cases, and this is the orange bars are from the placebo arm of the amiodarone study in cardiac arrest, and you see that in every time period, patients treated by ECPR do have a better prognosis than patients treated by conventional CPR. And the question is, so when is the brain, the patient can still recover? And you see there's quite a lot of recovering patients, even resuscitated for 1 hour or maybe even more than 1 hour. And the truth is that occasionally we really see patients surviving more than 1 hour. And we had, of course, patients surviving more than 90 minutes. This is exceptions, but the problem is you can never see and decide and identify a patient during the CPR and during ECPR, whether it is going to survive or not. This is the first randomized trial by the Minneapolis group comparing standard and ECPR in patients with refractory cardiac arrest. Those patients were randomized after 50 minutes of unsuccessful CPR. And you see in blue, patients who were treated with ECPR survived in more than 40%, 6 out of 30 patients. 6 out of 15 patients, compared to just 1 patient from the standard group, and it applied also for the long-term outcomes. So definitely the study is positive in terms of ECPR use and has been stopped by DSMB for the benefit in the invasive arm. In contrary, there has been several studies showing that ECPR is not easy, and even well-trained systems like this one in Copenhagen has shown that before ECPR and after CPR, the results were not better or even slightly worse in terms of neurological outcome of patients treated by ECPR. And similarly, this large study encompassing almost 28,000 patients comparing intra-arrest transport versus continued on-scene resuscitation has shown 4 versus 8.5% in favor of continued on-scene resuscitation. And this is important to say that not everybody will benefit from ECPR, but a subgroup of this study has shown nicely that patients with truly refractory cardiac arrest over 30 minutes might eventually benefit from intra-arrest transport. So the problematic is complicated, and I'm going to show you the presence of ECPR and this kind of a Prague approach we propose and we are using for past more than 80 years. We have published our our design paper in the Journal of Translational Medicine in 2012. And very recently, actually 1 month ago, we have published the results of our randomized controlled trial on ECPR in JAMA. So you can read it in the full text. Let me briefly introduce this study. This study compared invasive strategy, which was a bundle of early transport under mechanical CPR, ECPR, and immediate invasive evaluation to standard advanced cardiac life support in refractory out-of-hospital cardiac arrest. We enrolled patients 18 to 65 years of presumed cardiac cause, and they were electronically randomized to invasive or standard during on-scene ongoing chest compression. So this is important to realize that we randomized patients during ongoing CPR on the scene via telephone and electronic database. The study was conducted from 2013 to 2020, and we have enrolled 256 patients, and the study was stopped by the DSMB based on the pre-specified criteria. This is how the resuscitation is being provided in Prague. Prague is a city of 1.25 million people, has one dispatch center. We use a rendezvous system with a physician on board and the paramedics. In the blue pins, you see the stations where the paramedics are. The circled pins are stations with the paramedic, and our center is located in the center of the city. Transport times is usually 15 to 20 minutes from all over the region of Prague. The great advantage is that the Prague is covered just by one emergency service with one dispatch center, so everything can be very well coordinated and organized. We did have an early alert system for out-of-hospital cardiac arrest, and this is SMS automatically sent from dispatch center to the phone of the coordinator. And you can see the telephone-assisted CPR starting time and the age of the patient. So we see every occasion when telephone-assisted CPR by dispatch center is initiated in the region of Prague, and then we can prepare the team eventually for ECPR if the resuscitation is unsuccessful. How was the flow of the study? Within the study period, we had more than 4,300 CPRs for cardiac arrest, and ultimately, after exclusion, a lot of patients not fulfilling criteria, we randomized 264 patients and analyzed 256 patients. So this is 6% of the all patients with cardiac arrest, which is nicely correlated to previous studies showing that only 5 to 10% of patients are prone and are suitable for ECPR. Our baseline characteristics, 80% of males, 40% on a public place, 60% of patients with ventricular fibrillation, and very high percentage, 99% with bystander CPR. I should announce that the average bystander CPR percentage in Prague is over 80%, presented in the EUREKA 2 study. And patients were randomized after 25 minutes of CPR, so exactly as proposed by the Canadian study. We had a long cardiac arrest, 46 minutes in the standard arm and 58 minutes in the invasive arms. Patients were very ill, metabolically extremely sick, with the pH on admission 6.9 in the invasive arm and 7.0 in the standard arm. This is our results. In the primary outcome, which was survival with a normal or normal neurological impairment in 180 days, was 31.5% in the invasive strategy and 22% in the standard strategy, which was not statistically significant, however, with the evidence of trend. But what you have to realize is that we had a very high survival in the standard strategy arm, and this was caused by the training and improvement of pre-hospital logistics. So what happened actually is that we had exactly the estimated survival in the invasive strategy arm. However, due to training and the perfect coordination, we also increased the survival in the standard strategy arm. Therefore, the difference was not significant. However, we had a significant difference in the neurological outcome, statistically 31% versus 18%, and basically same result in the cardiac recovery, despite the fact that numerically there was a difference. In the subgroup analysis, in patients with shock algorithm, you can see that almost 50% survival in this subgroup. Patients in invasive arm survived 180 days with normal neurologic outcome, which is extremely good. And also in the subgroup of 45%, those patients actually profited from the invasive strategy, so truly refractory out-of-hospital cardiac arrest. And this is here shown that in the subgroup of more than 45 minutes, statistically significant difference in favor of invasive strategy. And it needs to be noted that out of those 6 patients in the standard arm, 4 of them were actually crossed over from the standard to invasive. So if we use intention to treat, it's 6 versus 20. But 4 of those 6 were actually treated invasively, even more demonstrating the benefit of the invasive approach. If we compare our study versus ARREST trial, so the first 2 randomized trials, they are very comparable, mainly males with a high percentage of bystander CPR, time of randomization 25 and 50 minutes. And you can see very high survival in the invasive arm, the whole population 32%, but the VF population, which is similar to the ARREST trial population, 49% and 43%. So very high survival in both studies. So let me shortly conclude in 2 last slides that not ECLS alone, but a comprehensive approach, including ECLS, may have an impact on the logistics. Now we have technology and we have to define and still probably replicate the results in a multi-center study. Our study is a negative study in terms of intention to treat analysis, but with many positive findings. First, very high percentage of bystander CPR and despite CPR, 2 times higher survival in the standard strategy arm than we expected, excellent overall survival, and true benefit in subgroups. So let me conclude that the future of ECPR is very sunny. ECPR should be a standard of care in selected patients with out-of-hospital cardiac arrest. Pre-hospital logistics determine the chance for survival, and perfectly functioning in hospital ECPR team is mandatory. We need to train this. Complex post-ECPR care, nurse-patient ratio 2:1 is necessary, and also complex post-discharge care has to be established. Thank you for your attention.